Okay, good afternoon, everyone. I'm going to just put my mask down a minute. Welcome to the forum. I hope all of you had an excellent Jubilee weekend. At least it was good weather, sort of. Lots of good television anyway. So to those of you who are in the room, we have flapjacks. This is your incentive for attending the forum in person. And thanks to all of you who are dialing in. As ever, we have excellent speakers. This week, we have Tristan Barrett, who is well known to all of you. He is a urogenital radiologist. He's nodding, going, yeah, okay, I'll take that one. However, Tristan is best known for his excellent work on prostate imaging. And he's done a variety of things. So not only has he honed his skill doing, basic MRI and prostate imaging, but also more advanced techniques. Now, hyperpolarized MRI and prostate imaging, and also acetate, C11 acetate, PET imaging. He's then taken what he's done and then influenced guidelines, not only on a UK level, but also on an international level. And it's the translation. It's not only doing the work, doing the research, but it's also translating it into the evidence-based guidelines, which is absolutely key in imaging. Because there's no point us, spending our time faffing around, having a lovely time with, creating pretty images if they don't actually impact on clinical practice. And the way for things to impact on clinical practice is to get them into nationally accepted guidelines, which means we can then use them in the NHS. The CCGs will then commission that work. So without further ado, I'm going to hand over to Tristan. I unfortunately have to go to another meeting with the VC of the university who's giving a talk, which is in parallel, but will not interfere with this one. I think this one will be absolutely excellent from Tristan. And I just want you to pay attention on how he has translated the work that he's been doing to the clinic, and then listened to what the clinicians have said in response, and then taken what their requirements are, what they need from imaging, back to what he's doing. Because while it's fantastic being a scientist and an imaging scientist, but the things that we clinical academics have is that we have that ability, or we have the opportunity, which we must try and use at all times, is that we are working at the coalface. We are doing the clinical work. And so we should listen very carefully to what our colleagues are needing in terms of advancing patient care. And I think that, Tristan, absolutely, that's one of your huge skills and strengths in academia. So thank you so much, Tristan, for agreeing to do this. I'm going to hand round the flapjack. So please come in person to the meeting in future. If you can't, it's just great to have you online and listening. So thanks so much, Tristan. Over to you. Cheer at that point.
Thanks, Fiona. I'll probably try and stay closer to the microphone for those online to hear a bit better. So we've got a few in the room here and several online. So this is the overall title of my talk, but I guess the first question here is if the slides work. Is why. So I guess this is probably what everyone says when Fiona asks them to do forum, is why. So why me, why now? So actually the reason that I'm giving this particular talk is related to the Ronken Professor Award that I got last year, which is for this current year. So you can see there's a list of various recipients over the years. Some are very familiar to the audience in the room here. I'm sure there's several ex-Cambridge trainees. So Tom Termazai, a couple of years ago, who now does the podcasts. Owen Arthurs, who was a trainee with us, and Odie Toms, who's now come back to us. and others that have come from this professorship to give talks within this very forum. So that's the reason that I'm giving the talk today, and this sort of forms part of what the Ronkin Professor role involves for those that might be interested in applying in future. So the only stipulation is you have to be at consultant level, you can be academic, you can be clinical, and you can't be at the level of professor. So if you're about to get promoted to professor, you better apply quickly before you get to that level. And there's various things that the role entails. So probably the main one here is the one at the top here, that you have to go and visit a minimum of 5 UK training schemes. So there is an acknowledgement now with COVID that these could be online or in person. And at the time that I was appointed, that was very much up in the air. My predecessor, Joe Jacobs, he did all of his visits online. I'm hoping to do most of mine in person. So at least 5 UK training schemes. And you also join the ClinRad editorial meetings, which are at least twice per year. I'm actually on ClinRad editorial board, so I already joined those meetings anyway, and provide advice to the editors, sub-editors on research-related issues. And you form part of you're a member of the Clinical Radiology Academic Committee for 2 years, so this year and next year for me. And then the final one is to organise the RCR Research Day in the year following appointment. So for me, that would be in November 2023. So that's sort of the overall role of the professorship. In terms of what I'm doing for the training schemes, you have to put forward in your application what you're going to do within that scheme. So depending on the individual scheme, it might be a half day, usually it's a half day, it might be a full day. You give workshops and lectures aimed at the registrars predominantly, and aimed at getting them interested in or how to get involved within research. And then typically there'll be a clinical type lecture. Similar to the one I'm giving now, I also do one on small renal masses, which actually tends to be a bit more popular. And then in terms of the workshops, these are the 3 talks I give depending on time. So I typically give a research careers in radiology talk. I've only done 1 visit so far, but that would be, I've agreed the format for the other ones. And then it's either 2 workshops or 1 workshop, depending on time commitments, on how to make an impactful poster, which is based around my experience from the other side of the fence, particularly the RSNA Educational Committee, on marking posters for either multi-systems I worked on previously and now more recently GU, and then how to approach writing a paper. So do you start with the abstract, as some people do? Do you start with the figures? Do you start writing the introduction or the methods as you go along, and where does that all fit in? So that's the sort of the background to this, and this is where I am with the Ronkin Professor visit so far. So although I meant to do 5 visits, I've had interest from 9 different centres, including Cambridge. So that's a visit, but it's not really a visit. I don't have to go very far for that. And at the top here, you can see Scotland, I managed to do in 1 fell swoop. So I linked into the BSUR meeting that I was attending anyway in Edinburgh a couple of weeks ago. The Tuesday before that started, I did the in-person visit to Edinburgh, which is the South East Scotland training scheme. And they arranged that the other 2 Scottish schemes, which had already expressed an interest, would also join in now online. So we had 30 trainees in person and another 40 joining us online via Teams. And then Hull, I haven't arranged yet. They want it to be online. They're not doing in-person visits. Guys in St Tommy's, I've tried to contact them a few times. They're just not replying to the emails. For our registrars here, I'm taking over one of the Wednesday afternoon sessions in early September. Sheffield is October, and these are sort of geographically close to each other, which are relative really. It's a long way away down to Plymouth, but I'm doing those on consecutive days at the end of this month. So I'll probably end up doing 5 in-person physical trips, plus the 6th being Cambridge, 1 online, and the other 2 Scottish ones, which we've done online as well. So I've sort of gone over and above the 5 visits, or I will have done. So that's the Ronkin Professor, and that's why I'm here today giving this particular talk. So let's go back to the talk. So prostate MRI from bench to clinic, back to bench. So this is going to jump forwards and backwards in time a little bit. it's like anything I think you watch on Netflix these days. They try to do this thing where they do flashbacks and there's the present time, then they go back and all these different things. So there is a bit of jumping around. So that's how I'm justifying it. I don't quite have Netflix's budget, but that's why I'm justifying jumping around between different time points. So a bit of background first. So prostate cancer is common. It's the commonest UK male malignancy, unless you count things like basal cell carcinoma of the skin, which most people don't. So it's the commonest male UK cancer, and its incidence is increasing over time, mainly due to the aging population. And actually, it's pretty close at 50, just over 50,000 cases a year. It's pretty close to breast cancer incidence. And there was a story that made the BBC headlines a couple of years ago when prostate cancer actually overtook breast cancer in terms of incidence per year. And they're sort of hovering about the same level, and one year one will be higher or the other. But the point is, it's a very common cancer. But although there's 50,000 cases per year, only 11,000 men die of prostate cancer. So it oftentimes is a relatively indolent disease. And the idea is to identify the aggressive tumors and to either not identify the less aggressive tumors or treat them with a relatively conservative management plan. And this is how we used to work up prostate cancer. So it would be a transrectal ultrasound guided biopsy. Now the ultrasound was guiding the needles to the prostate, but not to the tumor. So if we look at this example here, and I'll use the arrow, so hopefully they can see that online. This is an axial T2 image of the prostate. And then if we put the overlay of the histological map, there's a large anterior tumor, which actually has extra prostatic extension. And there's also, because prostate cancer is often multifocal, a small secondary lesion here on the left-hand side of the image, the right-hand side of the patient. And ultimately, a TRUS biopsy will only, even though we stick 12 needles into the gland, will only sample 1% of the tissue. So it's not sampling 99% of the tissue. So there's obviously room to miss things or to undersample them. So if we stick a needle here, we might hit this secondary lesion here, which is an insignificant lesion. And we say this is not an important tumor, and we miss the anterior lesion. So we know that TRUS biopsy needles will undergrade, as in this case, this needle biopsy here, in around a third of tumors. We could stick a needle on the other side here, and we incorrectly say that the patient has no tumor. And we know that TRUS biopsy will miss tumors in around 50% of cases. So clearly that is not that good as a test. And if you think about that in terms of other tumor types, it's a very unusual step for us to do, to go straight to biopsy without an intermediate imaging type test. Now, it might not be radiology, it might be an OGD, it might be a colonoscopy, it might be a visual assessment if it's a skin lesion, but there's some sort of imaging type assessment where you then see an area that you look suspicious, abnormal, and then you move on to biopsy. So this was quite a strange thing to do. And if you put that in the context of, let's say, liver, sticking needles randomly into the entire liver, hoping you detect a cancer, or an entire breast, it would be a very unusual thing to do. So there's good reasons for it. It's a small gland. It's historically been difficult to image, but it's an unusual thing to do. So that's how things have changed. So that's now the current guidelines, NICE guidelines in the UK, top left, EAU, European Association of Urology guidelines in the middle, and the American equivalent top right. So this is the guidelines. NICE was first, so 2019, the other two in 2020. And if you can read the small print there, you don't necessarily need to, but it says that MRI is the first line investigation for people with suspected clinical, localized or locally advanced prostate cancer. And in the EAU guidelines here, strong indication for MR before prostate biopsy to guide the biopsy or to potentially avoid biopsy if it's safe. So we've got to the clinic. So if we go back to the headline of the talk, from bench to clinic, we've gone from bench to clinic. Okay, so how did we get there? That's the point. So how did we get from bench to clinic in the first place? So if we look back in time, these are some of the prostate images over the years. So clearly quite variable in quality. This is the first published MR image of the prostate, so 0.04 Tesla, large field of view, and difficult to see much of what's going on there. It progresses, so that was back in 1982. We jump forward a year. It's always kind of a bad sign where you need to put letters to indicate what's what, right? So we've got O for obturator internus there. We've got P for prostate there. even if you jump forward here, there's a B in there for bladder. So that's usually a pretty bad sign on radiological images. So we sort of progressed to 0.35 Tesla. This is a 0.15 Tesla. This is a 17 millimeter thick slice, this top right one from 1985. We're starting to get slightly better on the bottom row here. We're still at 0.35 Tesla. And then if we jump forward to 1989, this is now at 1.5 T and with an endorectal coil, which you can see in here. This sort of, this is the coil aspects here. So this is a typical appearance of an endorectal coil. And then the final one here we got from 1993, again with an endorectal coil at 1.5 T. So actually some big names in radiology for those that know that. Herb Kressel here is the author of this paper. He used to be the editor for many years of Radiology, the journal, and Heavy Freechek here, who's a very big name in radiology, who's still working at Sloan Kettering Hospital in New York, previous president of the RSNA Association. So clearly we've got a lot better over the years, and we've got to this point here. And this is sort of where we're getting to now. So this is taken from one of our papers, but other people are doing equivalent quality. And I think a thing to bear in mind, somebody put this quite nicely to me previously, is if you go to talks like this in conferences or wherever, or you look at journals and you look at published images, they are pretty much the best image that they can produce. They might laugh at, oh, here's one, yeah, we just did this last week, but they're the best images they can get. And the analogy is, if you're showing, those that have kids, if you're showing people pictures of your kids to friends and family, you don't show the pictures where it's blurry, it's out of focus, or the kids screaming their eyes out, crying, or vomiting down the front of their top, right? You do it where it's all nice, happy families, their hair's perfect, they're smiling, right? So that's the equivalent images we're getting here. So yes, this is a nice one for us, but you put that in the context, these are their best images, right? These are their best baby photos, and they still don't look great to the modern eye, right? So that's how we progressed over time, and we've got to this stage here where we're getting really nice anatomical detail, and you can see the peripheral zone around the outside here, the heterogeneous transition zone in the middle, and you can see all the detail within these nodules of BPH, and you can see these kind of inflammatory type strands that we've got within the peripheral zone. Really great anatomical detail. So is that enough? Well,
Tristan, I'm sorry. Is it possible for you to use the mouse? We can't see the laser pointer on our remote screens.
If I'm moving it now, can you see it? Because can you see it when I'm moving it on my screen here? I'm moving it now.
No.
So I don't know how that's...
Can you get the laser pointer mode and PowerPoint?
Maybe if Ellis comes from next door, he can...
Should be down the bottom there. Sorry to interrupt the flow.
Laser pointer is... Can you see
there,
that now?
I can see that. Thank you very much.
Okay, good. Yeah. Hopefully that's it. So is that really nice, exquisite anatomical detail enough? Well, if you look at these four examples here, so I put an arrow to where there's an abnormality and happens to be in the right side peripheral zone in each of these four cases, and only one of them has tumor. The others are just benign mimics or benign disease. So I put this up a couple of years ago in one of the RSNA GU interactive sessions. So there's about 100 people in the audience, and most of them probably have a bit of a GU interest. I mean, you know, those who go to RSNA, I'm not going to go and see a neuro lecture, right? So I might see a GI lecture or gynae, and I might not have a particular interest, but I have more of an interest in those. And most of the audience will have at least a passing interest or a real interest in GU. So around 100 of the audience, and 0 got this right, which is almost unprecedented that 0 get it right on that interactive scoring system. Because just by chance, you'd expect a few of them to get it right, okay? So none of them got it right. And there's a reason none of them got it right is I led them down a garden path and I showed them a particular case that we'll come back to why it's the answer for this. But the point is, low T2 signal alone within the peripheral zone, particularly if it's non-focal, is quite non-specific. And there's lots of other mimics to tumor that can have these appearances. So if you were a betting person, that's the one that looks most like tumor. It looks mass-like, and you would think, without any other sequences, you would think that's the most likely to be tumor. And most of them fell into that trap. So we needed some other things to help us out. So that's when functional imaging came in. So this is the first paper looking at spectroscopy from 1988. So that was the first to be looked at. The next was DCE MRI. So this is published in 1993. And relatively late in the game, this is the first DWI, diffusion-weighted imaging paper from 2002. Now, this still doesn't look great, this image here, right? They're pointing to something that they're calling tumor, I think. This also doesn't look that great. This is a B0 and a B400 image, which you can't use diagnostically. In that paper, they did go up to B800, which by current standards and international guidelines is still too low. You should be getting at least a 1400 for the B-value imaging. But they did still show some good results, and they showed a difference between tumor and a normal peripheral zone and normal transition zone. And they also did ADC maps within that. And it was probably the first time this happened was the ISMRM meeting in Seattle that I attended. And I was at the time working at NIH in Washington, and we were putting all our chips in the DCE basket. And several other centers, including UCSF, were putting all their chips in the spectroscopy basket. And not many people were paying attention to this new kid on the block. And almost half the prostate lectures at ISMRM were about DWI. And I went back, my boss, Pete Choyke, at the time, hadn't gone to that meeting, and I was feeding this back to him. And we had been acquiring DWI, we hadn't really been paying attention to it. We started looking at it in the next few clinical cases and thought, actually, there probably is something in here. So it was quite interesting to be at that sort of cutting edge of that change in practice with DWI coming in. So let's go back to our cases. So these are the 4 cases, and what are the confounders? So this is an ectopic nodular BPH up here. So it looks like BPH from the transition zone, just in the wrong case, in the wrong place. This is too low to be tumor. It looks like scar tissue from previous infection, inflammatory episodes, and there's no restricted diffusion. This is a pitfall we used to see quite a lot, less so now because we don't do biopsies before we do an MR, but this is high signal on the T1, it's hemorrhage, and it looks like tumor. And then this is wedge-shaped, which usually goes with inflammatory change, and on the T2 weighted imaging is only a score 2 out of 5, so not consistent with tumor. But the point is, in the peripheral zone, we particularly rely on the diffusion weighted imaging, and you can see on the ADC map here, even though it's wedge-shaped, it has marked restricted diffusion, and then that turned out to be a high Gleason grade tumor. And although radiologically it doesn't look like there's obvious extraprostatic extension, at prostatectomy there was early ECE. So with that knowledge and with those developments, we then had to sort of standardize how we perform the MR and how we interpret the MRI. And we have certain rules as to when we believe the T2 more, or we believe the diffusion weighted imaging more. So that's in the peripheral zone, diffusion weighted imaging. And then when we can use DCE potentially for a bit of problem solving or to get off the fence. So that's when the PIRADS guidelines came in. So originally came out in 2012, actually called the ESUR prostate imaging guidelines, retrospectively turned PIRADS version 1 when version 2 came out. There's been 3 iterations. The current version is version 2.1, published in 2012, 2015, and the most recent one is from 2019, so just over 3 years ago. And we can emphasize some of the issues here if we go to a couple of example cases here. So if we look at this one here, so there's 2 wedge-shaped areas on that right side of the gland. So we said wedge-shaped areas can often be inflammatory change. If we look at the DWI, only one of them, the more posterior, has restricted diffusion. And if we play the video, which I might have to get rid of the laser pointer to do that. And then you can see that same area is on the DWI, if that plays. So if you look at that same area over there, you can see that early enhancement on the DCE, whereas the other area is not enhancing. So although on the T2 we can't tell a difference between them, they could well be inflammatory, DWI clearly shows only one of them is tumor, and the DCE backs it up in that case. If we go to this, well, there's an area there that perhaps looks concerning. So let's look at the functional sequences. So on the DWI, there's a bit more restricted diffusion out laterally here, a little bit here. Certainly it's more marked on the lateral aspect, which is very difficult to see on the T2 weighted imaging alone. Let's go back to the laser pointer for the guys online. So this bit here looks like marked change on the B-value imaging and marked on the ADC. This is less marked on the B-value imaging, but does look marked on the DC. So this would be a score 3. This would be a score 4 out of 5. And this looks low signal on the T2. There doesn't really look like there's anything there on the right side on the T2 weighted imaging, but clearly the diffusion weighted imaging is showing us more. So let's now go to the DCE in this case. Eventually we'll go to play. So if you look at the area in the midline, that's not really enhancing, but the area out laterally on the left is enhancing. So this is another pitfall, that actually that area in the middle, the medial aspect, is the central zone. So it's a normal appearance of the central zone, which can be confused with tumor. And in that case, the DCE has really helped as a problem-solving tool to say, yes, that lesion laterally is very suspicious for tumor, but the area in the midline is not. That's just normal anatomy and a common pitfall. So often it's all the imaging in together for us to get the right answer. So that anatomical imaging and the 2 functional sequences that we use. So that's sort of how we got there with a sort of brief history lesson on prostate MR over the years. So how did we get into guidelines? So there's 4 real key studies in this in the period of 2017 to 18. Late 2018, leading to that change in NICE guidelines in May 2019, and subsequently EAU and AUA a year later. And combining these 4 prospective studies using MR pre-biopsy, so PROMISE in the UK, Precision in the UK, led from UCL, MRI First in Europe, and 4M from the Netherlands, it shows a very high negative predictive value, so around 92%. So actually what that means is, if the MR is negative, we can safely avoid biopsy in the majority of those cases, unless there's another very good reason for us to go ahead with biopsy. So that means overall, out of the men presenting to clinic, we can save biopsy in 1/3 of those men. Whereas previously, we biopsied all of them indiscriminately. So that's a good point of prostate MRI. The PPV is only around 50%, which isn't great. What it means is we can't just say you've got cancer based on the MR imaging alone. We do need to go on to do biopsy, but that's not that bad or that unusual. We do that in almost every tumor type. I mean, there's very few exceptions to that. Some of the blood-borne malignancies, myeloma, perhaps you can do without. Renal, sometimes we go straight to surgery when it's a large mass without biopsying. Testicular lesions in GU as well, we often go straight to surgery without biopsying when the radiology is indeterminate or convincing enough. So it's not completely unprecedented, but most of the time we do stick a needle in and do a biopsy. So that's what that tells us, that we have to do that. But 50% still isn't that good, and potentially we could avoid more biopsies if we were more confident with the PPV. And this is just sort of an overview of some of the meta-analysis looking at that. So you can see the MPV reasonably tight and consistently high. PPV a little bit all over the place. So this is sort of, so 50% is, let's just get the laser pointer back up. So 50% is there, right? And you can see that overall they're probably around that. There's some that are more, some that are less, but there's huge variation within that, within the different centers, and the error bars are large as well. So this is 26 centers across North America. So why is that? Well, it was quite a heterogeneous group because it wasn't a prospective study, it's retrospective. So whether men had already a diagnosis of prostate cancer and on active surveillance, whether they had no diagnosis of prostate cancer, whether they had had a previous biopsy which was negative or had no previous biopsy, they were all included in this. So there's a very heterogeneous population. Also, the definition of a positive MR changed between centers. Some it was a PIRAD score of 2, some it was a PIRAD score of 3. So there's lots of heterogeneity in there. So that will explain a lot of these differences, but still the PPV is only around 50%. So what is definitely true is that the rule out ability of the test is much better than the rule in ability. So if we've got a negative MR, we can be confident, or certainly more confident there's no tumor. But if we've got a positive MR, we're not that confident and we still have to go on to do a biopsy. And this is another reason why there'll be that variation. So this is taken from a study that I'm doing at the moment with the ESUR group, looking at image quality. And this is a multi-reader study that we're doing. There's several of us that are scoring these online. There's 120 cases from multiple centers around the place. And you can see, even without an expert eye, there's a huge variation in quality here. So this top left here, they're generally getting better as we go down to the bottom right. I've sort of set them up like that. But this is a very noisy image here, very difficult to see any detail within the prostate. This is quite blurry, but also low signal in there, just like this case here, this case here. And as we start to get down to here, you can see a lot more detail. There's no blurring in the image. You can see a lot more signal within the image. You can start to see that detail of the BPH nodules, as we saw in that example that we put from our center. So huge variation between the different centers. And that's based on the protocol, how they've set it up, age of the magnet strength, coil, lots of different things. So that will be another reason for the variation. So that's one of the big issues that we've got. So issues in the diagnostic pathway is the image quality, and also to a certain extent, the radiologist interpreting it, because it's sort of something you have to pick up. And generally with MR in tertiary referral centres, we're better than in smaller district general hospitals because we've got more of a subspecialist interest in it. We work within the MDTs, so we often give a better opinion. But as we've said, it's a very common disease. So there's around 120,000 referrals per year. So it's not realistic that that's only done in a handful of centres that are the teaching hospitals or the tertiary referral centres. So we need to be doing the imaging in all the centres. So the kind of the key questions are, how do we control image quality and how do we improve interpretation? How do we address those 2 points, particularly for some of the smaller centres? And then beyond that, how can we improve particularly the PPV, which we mentioned is quite low, but also maybe the MPV? I mean, it's high at 92%, but perhaps we can get it a little bit higher. And then beyond just saying cancer, yes or no, can we work to risk stratify patients to say this is a low-grade cancer, this is an intermediate-grade cancer, or this is a high-grade cancer, because that affects how we manage the patients. And biopsy can give you that, but of course there can be a sampling error. And the idea of MR is, or imaging is, it can sample, in inverted commas, the whole lesion, so it can give you the better picture. And in terms of what we want to do, this is essentially disseminating the current best practice as it stands today, and this is trying to advance the best practice, clinical practice. And there's different ways we can do this. So guidelines, HIRAD's guidelines, education, certification, I'll mention, so CME credits, workshops, conferences, and potentially there's a role for AI to assess image quality or to augment interpretation or to improve image quality. And we'll see some examples of that. And in terms of advancing current clinical practice, that's really looking at more novel imaging techniques, which we'll also touch upon. So disseminating best clinical practice, well, this is actually where the biggest bang for the buck is. So this is sort of a theory taken from business practice. And I've just substituted quality in at the bottom here for image quality, let's say. And the idea is you look at performance across a business or whatever that practice may be, and you'll have typically a Gaussian bell-shaped curve distribution of productivity and performance. Now you could say, well, the top 5% are performing really well, the bottom 5% are terrible, let's just get rid of all of them, right? We'll just sack the bottom 5% because they're not performing. It's the sort of, big companies sometimes do that, innovative companies like kind of Netflix, Twitter, they'll do that because they just don't think they're right for them. So you could do that, but if you try to improve performance across the board and you shift that curve to the right, you can see if this is your cutoff of acceptable quality, now suddenly by doing that, just shifting it a little bit to the right, a lot more percentage-wise volume under the curve are meeting that threshold of quality. So actually, when you do whatever intervention it is, or multiple interventions, if you can shift the curve to the right, you're in a much better position than just getting rid of the worst performing or the bottom 5%. So that's the sort of the theory behind trying to improve MR quality. But we don't live in a silo in isolation in radiology. So this is the whole diagnostic pathway. So it starts with radiology, then it goes on to urology who perform the biopsy, then it goes on to pathology who interpret the biopsy. So there's lots of steps. And when it comes to our role here in radiology, there's patient-related factors that can affect the image quality. There's the magnet-related factors, radiographer-related factors about acquiring the images. And then there's also radiologists interpreting it and where they are on their learning curve, how experienced they are in doing that. So all of those may vary between centers, but likewise, some of these steps later in urology and pathology will vary. And we can't control those as much as we can control these ones. And that quality is important at all steps of the pathway, but it's sometimes important to remember where we sit within that. And if you're calling a lesion and it comes back negative, well, is that because you've overcalled it and you've interpreted it incorrectly? Or is it because the operator with the biopsy stuck the needle in the wrong place, missampled it? Or is it even because the pathologist has incorrectly assigned either a Gleason grade that's different or missed the small focus of cancer? And we sort of think of pathology as black and white, but it's not. There's actually quite a lot of intra and inter-observer variation when you look at pathologists, and that's true for GU pathologists and prostate interpretation as well. So all these parts of the pathway also are important from a quality point of view, but we can only kind of control what we can control. And in terms of that interpretation, one way potentially is certification. So this is a UK consensus process that I was the lead author on from published about 18 months ago. And almost simultaneously, there was also a European ESUR, which is the Radiology Board, and ESUI, which is the imaging section of the EAU for urologists, combined groups. I'm on this paper as well as a consensus process, putting forward the case for having a badge, a certification in being able to report prostate MRI. And it's a little bit controversial having to do that, particularly if you want to include an exam, which both of these documents recommend. For radiologists that might be a long way post FRCR and having to go back and do an exam or being questioned might be controversial, but it's not without precedent. It does exist within mammography for breast imaging, CT colonography, and also within cardiac imaging for CT and MRI. So it's not completely without precedence. And if we look at sort of forced, if you like, peer review of a percentage of cases, that also happens in PET-CT imaging. So it's not completely unprecedented. And it is starting to come in. So in Germany, this exists as a thing. It's the only place in the world where a certificate, so despite us and the Europeans and also the Americans suggesting this. So this is from the ACR, American College of Radiology in the States. It's only Germany where this exists as a thing that you can get a qualification in prostate MRI. So it is out there, but it's just not widespread at the moment. And in fact, I was the author on this recently published AJR, which is a narrative review, an invited panel review with representation from radiologists from North America, South America, Asia, Europe, and UK, me. So it's something that's probably coming. It's a bit controversial, but I think that's the direction that we're traveling in, to at least have a badge that you're meeting a minimal level of qualification for reporting prostate MRI. But how do you know if the image quality is good? So I think this is sort of a nice analogy that sort of, if you go back through video games and you look over time, you go back to 1980, this was the quality, right? So if you're stuck with an Atari or whatever it is from 1980, you might still think that that's the best imaging quality that you can get to. If you fast forward to 98, it gets a little bit better. And then you get to the sort of the current one, FIFA 21 from last year, so much so that Kang Lee is my PhD student. I showed him that image and he thought it was a photograph. He didn't believe that it was a video game image. So I had to make it even bigger so that you could see it. And if there are any Tottenham fans in the audience, I'm looking particularly for Nick Carroll or Nadeem Scheider, but they're not there. If you're a Tottenham fan, you notice that it's quite unlikely that Lucas Moura would play. He doesn't play that often. And Pierre-Emile Højbjerg here is a defensive midfielder. He's not usually the first celebrating a goal. And even if he does, he kind of does it on his own because that's his thing. So it's not a realistic image anyway. If you're a Tottenham fan, you would know that. But that's how we've progressed in video game technology and image quality. And it's the same in prostate MRI. So we've already looked at this, right? So you have to sort of know, and the advantage we have in the specialist center is, number one, we're involved in MDT. We get imaging from lots of other centers, particularly around the region. We sometimes, we dial in Jersey, dial into our MDT, Northern Ireland did previously. We often get second opinion requests for imaging or from surgery or from oncology from places like Nottingham or even some of the London hospitals. So you see images from lots of different centers, so you've got something to compare to. But if you work in a small center, you may never see anyone else's imaging, so you might not know any better. We also in the teaching hospital tend to look at the literature a bit more. So you see those baby photos, as we've described, their best images from other centers, and you participate in conferences. So again, you see those images projected in conferences. So you know what is achievable and what is good quality. But if you're working in a more siloed and smaller center, you may not know that. So that's one of the main issues. And image quality is a big thing. So more recently, there's this thing, PyQual, which is a way of grading the quality of the image. That's a 1 to 5 scale, 3 being acceptable quality, 4 being excellent, and 5 being the best you can get, right? So that's the sort of threshold is 3. And the idea is we could or should score all our images. Every time we report an MR, we also score it for image quality. And in PIRADS, if you follow PIRADS, the latest version of PIRADS, it does tell you, it's a good menu of how to set up your MRI and to get the best quality imaging. But actually, just compliance alone doesn't guarantee that you'll get quality. So this is a multi-center study that I did with NIH. This was 60 different centers. And this is for T2. It was the same for DWI. And you can see if you comply with the PIRADS guidelines in each of these categories, so up to 7 categories, generally it goes like this. So the more you comply with, the better quality imaging you get, but you still have these outliers. You have a couple of centers down here that comply 7 out of 7, all the parameters, but still are producing poor quality imaging with that threshold of 3 being acceptable. But you also have outliers in the other direction that don't comply with that many, in this case 2 out of 7, in this case 4 out of 7, and they're still producing good enough image quality. So part of this is the insight to know what good quality imaging is, as we saw on the previous slide. And the other is the knowledge of how you can alter the parameters and work in and around the guidelines to optimize that. So that might be increasing the slice thickness, it might be using calculated p-values or different other tricks, increased temporal resolution of DCE that's outside the parameters, but gives you more signal or less noise to get you better quality imaging. And that can be helped with, with engaged radiographers, with MR physicists, with app specialists from the vendors as well. So these are all from our center, right? So these are not the baby photos. So we know we do good quality imaging, and I've shown you examples of good quality imaging. But all these cases from our 3T scanner, the imaging quality looks terrible, right? So why is that? Well, this case up, it's got hip replacement, 2 bilateral hip replacements. All the rest is due to motion artifact. So mainly due to sort of rectal loading, but also patient motion. So if we look at this example here, I might have to come off the laser pointer again. And so this is the ideal situation. We have no motion. So you see the prostate here, it will light up with DC as it comes in. And you can see the rectum posteriorly here is not particularly loaded, and there's almost no movement in that prostate whatsoever, okay? But let's go on to this example here, and there's different types of motion that we can get. We can get rectal spasm, which is the most common. We can get bulk motion, patient moving around in the magnet, and we can also get respiratory motion, which is rarer for us in the prostate because it's in the pelvis, it's away from the diaphragm. But if somebody's hyperventilating, you can get that. So this patient has all types of motion because they're claustrophobic, they're really not enjoying being in the magnet. You can see the rectum spasming. You see this thing where it jumps side to side, that's the patient moving in the magnet. And if you look sort of here, the vessels, yes, are pulsing, but you'll see the the anterior abdominal wall moving up and down with the patient hyperventilating in the magnet. So we've got all three types of motion in that case. So we're going to get blurring and we're going to get poor quality imaging, and that's on a patient level rather than a center level, rather than a scanner level. So we can try to mitigate that, but we know we're producing good quality imaging, but in these individual cases, the imaging quality is poor. There are certain things that we can do, physical things, to try and improve quality. So rectal preparation, emptying the rectum, sometimes that's just advising patients to go empty the rectum before the exam, which is what we do. Others, it can be more invasive, giving suppositories or enemas, or sometimes rectal catheters to suck out gas. During, we give antispasmodics, we give Buscopan to reduce the spasm. That works very well, but it does have a half-life, so it starts to wear off by the later sequences. And you can potentially, for DWI, where you have air anteriorly, if you put the patient prone, the air will move away from the rectal interface of the prostate. The practicalities of doing that in busy lists, though, are just, it doesn't happen, because you have to, number one, radiographer spot it, then go in, do something about it, get the patient out of the magnet, take the coil off, turn them prone, put the coil back on, headphones back on, back in the magnet, repeat the localizers, repeat the sequence. And it's not practical to do that. Even a 2.5 minute sequence of DWI will probably take 10+ minutes to repeat in prone imaging. So that insight that we mentioned, Pyqual is good, because clearly a negative MR, in that case on the right with all that motion, is not the same as a negative case on the left with the good quality imaging. So it's good quality imaging, we can be confident there's no lesion there, but there's all that motion and blurring, then we can't be confident. So the bottom line of our report, which there's no lesion seen, has a very different interpretation depending on the image quality on an individual patient level. So that's why it makes sense to put that Pyqual score out there. But actually, the inter-reader agreement for this is not that great. It's around 0.47 from previous study. This is our work, similar levels, around 0.5. So what's probably the best thing to do is have an AI tool that can do that for you, because you don't want to have to go out your way to do it, and potentially it's more objective and better than the subjective opinion of the radiologist trying to do that. So that's something that we're potentially looking at in collaboration with Lucida Medical, and Dimitri's recently been appointed. He's working on that as an ML physicist, and Kang Lung, PhD student, is going to be working on that as well. So something like this, I think, is where AI could come in and help augment what we do as radiologists to detect image quality and report it for us, because we don't have time to do it in a busy reporting list. So it's already there, done, available for us. That really helps us out. But what else could we do? What else could maybe the vendors do? So we've already said a couple of times that we've improved over the years. So why not improve some more over the years? So a lot of that has been due to magnet strength, parallel imaging, coils, and software solutions and post-processing. But can we do even more than that, or can we do new sequences? So if we look at T2, there are some proprietary sequences available from GE that we use to help us out, and DWI, synthetic DWI, which is done by most of the vendors I mentioned. And then there's a few other variations on DWI. We've used Muse here previously. I think in pancreas, we use that quite a lot. And this Progress, which is a reverse polarity way of doing DWI. So you can see here a lot of motion, but Propeller, which is not an FRFSE, is this one here, is a different way of sampling case space. And you can see we lose a lot of that motion. Let's go back to the laser pointer. Suddenly everything's very clear on this. And we can even see a lesion here, which you would have no chance of seeing with all that motion. So same patient, same day, repeated the FRFSE Propeller sequence, and we suddenly get a diagnostic image. This is ARDL. We'll show this in another couple of slides, but this is the original image, and this is the post-processing denoising medium setting image. And you can see a lot more detail. There's no lesion in this case, but you see a lot more detail in the transition zone than you could with the noisy image that was originally acquired. These examples here, so Propeller rather than EPI, DWI helps particularly with hip artifact. And then these two more novel ones, Muse here and Progress. So actually, this is a very interesting one, because this is something we see a lot in prostate MR, because even a little bit of gas within the rectum here causes this signal pile up and slight warping there. So if we can reduce this and get an image like that, that's a really big deal for us, because it's very common to see this artifact. and just we try to work around it, and often we can. But if you can get rid of it with a different sequence, or possibly with post-processing, I don't know if post-processing is going to be enough to do that, then that's a big advantage to us. So there are things that are kind of on the market now or in development that can help us push this envelope up here and get better quality imaging beyond what we can currently do. So let's have a look at ARDL. So you might notice this is a bladder rather than a prostate, but it's just there to highlight a point here. So this is the original image here, which looks more noisy than this image here. So you can see everything looks a bit more crisp, a bit more smooth. So if you look at the bladder, and particularly the urine here, you can see a lot more noise in the background bladder there on the original image, whereas here it looks a lot more smooth, and that noise has been taken out of the image. So the post-processing, denoising, so air recon is, this is a GE name, but deep learning post-processing step. And you can also see there's an obvious tumor here and up here, but you can also see this tumor here, which perhaps you missed the first time looking on that side there, but it's more obvious on the ARDL image. And you can see sort of mesorectal vessels and other anatomy better on this image than you can in the original one. So this is how we're using it. So this is 1.5T. We've used it to go to a thinner slice thickness. So deliberately, we know it's going to be a noisier image. And then we set it that we use the ARDL to get rid of that noise. So that's a way you can do it, or you can potentially do faster imaging, which you know will have less signal, and then you can denoise it after the event. But there is a payoff here. So this is the original in this case. This is the low setting, the medium setting, the high setting. It starts to become a bit too false as an image, and it looks a bit too smooth and a bit too artificial. And actually, within the transition zone in particular, we kind of want the graininess of the noise, because we're looking for loss of that graininess when we're looking for tumor. So the happy medium is sort of the middle setting on this that we can do. And you got to be aware that if you go too high, depending on which area of the body you're looking in, it might push it a bit too far and be a bit false as an image. But that's how we're using it. We've only got it available on one scanner at the moment, but that's how we've used it so far. And it certainly helps in cases where we have a bit of motion artifact or a little bit more noise than we'd like. And I think overall, this is probably where we're going to get to. Right? This is the whole pathway as I showed it before, and the pathway that we're interested in, and QA and QC. So QA are things that you put in place to try and mitigate against poor quality, and then QC are things that you do to check that you're complying with those poor qualities. So these are sort of things that we've looked at previously when it comes to image quality, PIRADS, following the PIRADS guidelines, looking at AI solutions, high quality tests that we're doing it, vendor-related QC on the magnet, phantom testing, and then radiologist interpretation, following PIRADS guidelines, going to workshops, getting CME credits, and then potentially things like certification, MDT review, peer review. So these are the sort of things I think we'd be working towards, and that's applicable across imaging types and tumor types as to where we'd ideally like to be. So that's the current practice, making that as good as possible. So that's the bulk of what it is, because actually, as that bell-shaped curve showed previously, that's where the bang for the buck is, and that's really what we want to do. In terms of advancing best clinical practice, some of that will be vendor-driven, perhaps AI-driven, as we've said. What we've done here, so particularly changing pathways, Fiona sort of alluded to that in the introduction, that's where we've had our most impact. So although the guidelines changed in 2019, we started doing targeted biopsies with the urologists in 2011. It was the first centre in the UK to do that outside of trial settings. And we started doing MR pre-biopsy as a dedicated pathway in 2015, 4 years before that came out on the guidelines. So we created a big database, and actually that's helped change the pathway. So 11 of our papers were cited within that 2019 guideline. So that's where the biggest impact has come. We've looked at a lot of novel MR sequences. These are not limited to these, but DKI kurtosis imaging, magnetization transfer imaging, Verdict version of DWI, R2 star imaging, also MR fingerprinting, and we're also planning to look at luminal water imaging and restriction spectrum imaging. And they can tell the difference between tumor and normal tissue. There's sometimes a bit of an overlap, and you can get a slight improvement in the standard care imaging, but you don't get an incremental improvement in the standard care imaging. So DWI, when that came in, because that started off as a novel sequence, a relatively novel sequence, that incrementally increased what we could do and improved how we performed, which I showed you with some case examples. But these ones haven't done that. So even if the advantage is you don't have to inject any agents in for them, But if you're not incrementally going to increase from a 92% negative predictive value, then actually even adding a few minutes to each scan, when you scan so many patients, 120,000 across the country, is a lot, right? So you have to be getting an incremental benefit for those to be routinely used. Then in terms of other things, so Fiona mentioned this at the start, we looked at acetate PET. It wasn't as good as we'd hoped, and it was quite a difficult study to get up and running, but in the meantime, PSMA PET overtook that, and we now do that as routine practice. This isn't the best example, it's an old example, that's uptake in the ureter there, but there's a node there posterior to the external iliac artery, iliac vein there, which is positive, which you can't tell from the T2 imaging alone. It's just a tiny node that's in there. So that's now part of routine practice. AI, we've looked at this sort of modeling sclerotic metastases, and you can produce in one image what you take 200 axial CTs to scroll through and show a urologist, and they might not see what's going on, and you're describing an MDT, but you can put two images side by side, very easy to compare and contrast over time for oncology, and to see where the burden of disease is. And then ex-nuclei imaging, which I'll mention in a second, but we've looked at sodium imaging, so non-proton based MR, and then a hyperpolarized carbon-13 MR is something that's very big in our particular center, led by Fergus Gallagher. And so what? With all those, that previous slide, so what? So I think always when it comes to research, you've got to ask that question when you start out. So what? What's the point of this? Where are we going to? So is there something that we can improve clinically, and particularly from a management point of view? So if we think about these novel techniques, is there a need for them? So is the standard of care imaging already good enough, or as good as it can get? And can we incrementally improve it? Because they're often technically challenging to perform. They may involve post-processing results. Most of those novel sequences that I showed did. So there's increased scanning time, as we mentioned, magnet time's expensive time, and you may need other ancillary staff to support that, and it may take you longer to report as a radiologist. So it's going to increase the cost. So if it's not incrementally improving what you do, then maybe it's not worthwhile to look at it. But when it comes to prostate cancer management, as I said, you split patients into low risk, intermediate risk, and high risk disease. And there is different treatment for these patients. So the low risk, we tend not to treat, we just watch them, because the balance of side effects of the treatment outweighs the benefit of treating the patient. So we watch to see if there's a change. We do the same with small renal masses often. So if we can confidently say it's low risk, and as we say, sample the whole tumor, then we can better risk stratify and appropriately manage patients. When it's intermediate risk disease, that's the point at which we typically try and do curative treatment with surgery or radiotherapy. And when it's higher risk disease, it might be more systemic therapy, or if we're aiming for a cure, a multimodal approach to therapy. So it is important to try and risk stratify patients, because it does affect how the patients are managed. So this sort of comes back to some of the points we mentioned earlier about stratifying and improving on PPV, MPV. So you have to think about the so what. What are the areas you can make a difference? So something like hyperpolarized MR, which is very technically difficult to do, very expensive, we scan more than 100 patients a month, so more than 1,200 a year. So we can't do it on 1,200 patients. So what's realistic? Maybe, sort of in the order of 20 to 30 patients a year is more realistic. So is there a niche area where there's that amount of patients that could benefit from this? So particularly in biochemical recurrence, where you've had previous radiotherapy and you think there's recurrence in the gland based on the PSA, our standard of care imaging is not very good at identifying that. So if you've got a novel technique that can improve on that, actually it's going from a lower bar. So the incremental value that you can get in that is much higher. And then you can offer focal salvage therapy. So that's something particularly that we're interested in looking at with hyperpolarized MR, because that's something where we can make in a niche area where we could potentially make a big difference. And then possibly selection for active surveillance, because if patients are on the borderline between low risk and intermediate risk, that's actually a big deal. You're saying either do nothing, watch, or do everything, take the whole prostate out with all the side effects. So for those borderline patients, it's a smaller number, it's more manageable, and potentially you can make a bigger difference to those patients. So that's where the so what comes in. You need to have that line of sight when it comes to research. And then briefly on hyperpolarized MR, it's almost obligatory that we have to put a slide on this. So this is a case here, T2 weighted imaging. You can see prostate cancer often multifocal. So we see the dominant lesion here on the left-hand side of the gland, there's a secondary lesion here. If we look at the lactate imaging, clear signal within this, but also you're seeing uptake in that secondary lesion. So we're seeing the second lesions as well. So we're showing more than standard care and more than just the obvious ones. So this is early, it's proof of principle, it's low-hanging fruit, but there is some potential there. There's been work by Nikita has particularly driven this, but obviously there's a big team involved. Mary's in the room here, Martin in the background, third year leading the program. Lots of people involved in this across tumor types. Nikita's sort of driven looking at what we're seeing with this imaging, and we can correlate the Gleason grade 3, 4, or 5 to different amounts of MCT, which is a transporter of pyruvate, and lactate dehydrogenase, which turns pyruvate into lactate. And there's a correlation with lactate signal with the percentage pattern of Gleason 4, which is particularly important for that decision-making point at low risk to intermediate risk, and to decide whether to be on active surveillance or to go for treatment. And which is also quite nice, this was picked up by the popular press. So when we published this in Nature Communications in mid-February, the Sunday Times published an article on that where they interviewed me, third year, and Nikita, and put a couple of our quotes in there. So it's nice to get that recognition in the popular press as well. It's just about 6 o'clock. So just to summarize, we are in the clinic, and it's integral using prostate MRI and also PSMA PET. So radiology is now crucial to prostate cancer staging and management and follow-up, and that's a relatively new thing within the last 5 years or so. Disseminating best clinical practice is crucial, as we've said, and image quality in terms of acquisition and reporting is central to that. To the bench. So we've gone from bench to clinic, and then this is the question about back to the bench. So that's questionable. And yes, it's good to advance best clinical practice, but you know, it's quite a high bar to achieve. Incremental value, low cost, and a lot of the different techniques won't meet that unless you can find a niche area that you can make a difference in. And actually, as we said, working on this, and that's what the majority talk was related to that, that's where the biggest gains are to be made, is increasing quality across the board. And then do think about that, those that are involved in research, the line of sight, where you're going from, the so what factor, and where you're potentially going for with how you can impact on clinical decision making. Okay, that's the end of the talk. Thank you.